This module will cover the use of the matrix gait trainer with those with stroke. Now, this is a little bit more unique than other modules related to spinal cord injuries or Parkinson's, is that we may or may not need to adjust the armrest depending on if there's upper extremity tone or spasticity. For an example, if someone has more of a flexor tone in the arm and they can activate a little, but they're kind of stuck here, we can actually adjust this to accommodate. Now, ideally, from a neuro standpoint, I know we don't want to facilitate more of a flexor tone, but I'm thinking more from a functional standpoint. If we're trying to really address lower body as the person continues to get rehab for their arm, this could be a way for them to still feel stable without the arm dangling, without them, you know, curling up and starting to twist. So really what we're focused on is what is happening below during the gait cycle, and we're trying to set things up in a way that the patient's more set up for success as they're walking versus if there's other compensatory patterns that happen. So I'm just going to use my right leg as my affected leg. I've had a stroke. Let's say it's more flaccid, and so you're guarding on the right side, standard stuff that you do for guarding for neurological patients. Now, assuming if I'm more in this flexor position and I'm holding here, as I'm stepping, most likely, as I shift, my leg's just going to move already just because it's flaccid, because of the tension. And you'll find that the patient will take a half step. They'll resist that motion because they don't want to put all the weight on that leg in fear of it, that knee collapsing. So there's two options. If the person does not have any activation in that leg, you're going to use both. That way, once the foot is there, you have a little bit more tension on the non-affected side to really make sure, one, that they put weight in this leg, and two, that they step all the way through. That way they're not going back and forth with a full step pattern versus a short step pattern. Now, as you continue, it should look like this. Again, their compensation will look more like this. And you'll find the more that you add resistance or more tension to the bungee, it really will force them to come forward, and then they'll start to feel comfortable with it because now they've gotten a chance to get multiple trials to put weight on the leg than they did before. Now, if the stepping through pattern is not an issue, then what we can do is we can take this one off as they advance. And now we're focused on just really increasing the activation in this hip and in this leg. So now what we're going to do is, assuming that this is the case, I will still use it as a way to help activate unilaterally in order to build the strength on this leg. And then what you would do for progression is you just go less and less and less on the tension of the bungee. Now, if the person had more of a flaccid arm versus a spastic arm, you could bring this back down to the normal height to level up with the other one. You can put whatever strap around the hand just to make sure that it's making contact. And then you can put the other strap on. And let's say the arm is more flaccid, but the leg might be a little bit more spastic. Or vice versa, you can interchange this. But if the leg is more spastic, then I'm going to put more tension on here just to make sure that that leg does come forward and that resistance backwards. So depending on the tension, you may have to adjust a few times, but as we're going here, and then I'm stepping through, and then even if I'm trying to shuffle through, I'll have enough tension to make sure at least I get 75% of the motion through. So working with this, and you'll find over the cycle of the gait trial, they will start to loosen up more, and you'll see that foot go more and more and more forward, passing the foot versus cutting it short due to some of the tone, whether it's using AFOs or anything like that, or not necessarily using a KFO, but an AFO on this would work great. A KFO, if that was the case, you could still use a foot strap, but then you could also use the knee strap, someone with a little bit more tone. And this, if someone's constantly going into hyperextension or not getting enough lift, now I have a double version where I can get a little bit more lift in the knee, break that hyperextension moment, forcing me to get that knee flexion moment and help recreate that step forward. So this is another way that you can utilize those with more tone. Maybe they're even more flaccid, they're hyperextension flaccid, and you need them to bring that knee forward. It's a great way for them to get more proprioception and assistance to bring the leg forward. You could even utilize this if someone was a lot heavier, a lot taller, and a good way to help start activating hamstrings, co-contraction between the quad and the hamstring as they come forward. So these are different options that you can use for stroke when it comes to making the cycle more efficient, so therefore reducing fatigue, and also making it to where they can reciprocate the motion without a lot of compensation. That's so important when we're looking at this. So however you utilize this, there might be even ways that you can utilize this that hasn't been talked about quite yet. It gives you the option to, whether you want to move the straps in, you move the straps out, you use the knee strap, you use the foot strap, but these are the ways that I found that have been really beneficial for these specific diagnoses, in particular to stroke, that you can utilize to help begin the process of gait training in full weight bearing with only the use of one practitioner in a safer way.